Great. So I think why don't we get started? So today I picked two topics that I think are relevant for everyone to learn, especially if you're in internal medicine, regarding neurologic emergencies. So the topics that I want to discuss today are: what do you do when you're suspecting acute ischemic stroke, and what do you do if you get a head CT and there's blood on the head CT? So we'll start with a case. This is a real case. So she was a 35-year-old right-handed woman. She said she had no prior medical problems, and she works as a barber, and while cutting one of her client's hair, she suddenly lost control of the scissors. So her coworkers said that she was confused, in their own words, and they also said she had slurred speech. So she was last seen 30 minutes prior to when we saw her. On exam, her blood pressure was 113/84. She had mild dysarthria but no aphasia. She had mild flattening of the right nasal labial fold compared to the left, and she had a right upper extremity pronator drift. So you want to evaluate neurologic emergencies the exact same way. So there's three primary steps. The first step, is this neurologic? The second step, what is the problem? And then the third step, where is this problem? So the first step is the most important one. Okay, if a patient has right lower extremity weakness, but they also have a hip fracture, then although it's possible to be a neurologic problem, it's probably not. You have a more likely diagnosis. Once you've established that the problem is likely neurologic, the next step is what kind of problem is this? And you're going to primarily do that by understanding what the temporal course of the disease is, and that's primarily done by the history. So neurologic diseases have very, very characteristic temporal courses, and based on the temporal course of the disease, you can identify whether it's a vascular process, an acute process, or a subacute process, something like an infectious or an autoimmune process, metabolic or neoplastic. And then once you've identified those two things, you're going to examine the patient. You want to find out where in the neuroaxis is this. Is this in the brain, the spinal cord, the dorsal root, the peripheral nerve, the neuromuscular junction, or the muscle? So if I were to summarize this case, and the way I would think of it is there's an acute onset of a new neurologic deficit that localizes to the left cortex. It was acute and it's vascular until proven otherwise. And once you've identified that it's vascular, you want to become a little bit more specific in where in the vascular territory is it. So I would say this is an anterior circulation problem and not a posterior circulation problem. And I would further say that since the face and the arm were involved more than the leg, it's more likely to be a middle cerebral artery problem. You can also say that since the patient has aphasia, it's a very proximal artery problem or it's a superior division problem. So stroke is extremely common. 1 American has a stroke every 40 seconds. It's very expensive. $65 billion a year is spent on stroke care. It's the third leading cause of death, but this last point is the most important one. So it's the leading cause of long-term disability in the United States. And the reason is if you compare it to a disease like myocardial infarction, if you have an MI that's big and not treated, you're going to die. If you have a stroke that's big, you probably are going to survive with a lot of disability. And that's one of the reasons it's so expensive. So this is the most important part of the PowerPoint. Does anyone know what this picture is from and why it's up here? It's from Seinfeld, good. And what happened to this person? He had a stroke. He had a stroke on the show, and Elaine is left to take care of him for the rest of his life. She doesn't, but he has profound disability. So the definition of ischemic stroke and TIA have changed since I was a medical student, and it changed in 2013. The AHA updated the guidelines, and basically it's no longer a time-based definition. So previously, if you had a neurologic deficit referable to a vascular territory and it was less than 24 hours, we called that a transient ischemic attack, and if it was greater than 24 hours, it was called an ischemic infarction. So that was updated in 2013 to a tissue-based definition. So in order to have an ischemic stroke, there has to be either pathologic or radiographic evidence of tissue damage. And an example of that would be a patient who has a neurologic deficit that lasts 10 minutes and then it resolves, and you obtain neuroimaging that shows there's actually an infarct. So that's called a cerebral infarction with completion of symptoms. It's completely tissue-based and not time-based. So you want to categorize strokes into 4 ways. There is either going to be related to small vessel disease, large vessel atherosclerotic disease, cardioembolism, and then rare things called non-atherosclerotic arteriopathies, like carotid dissections or cerebral vasculitis. So the pathogenesis of ischemic stroke is all related to blood flow and piping, okay? So the normal blood flow in the brain is about 55 milliliters per 100 grams per minute. And when you have reduced blood flow, you're going to get three regions based on how much blood flow you get. There's going to be an ischemic core that has no blood flow, and it's immediately infarcted tissue, okay? Additionally, you'll have two other types of areas called an ischemic penumbra or benign ischemia. And those get some blood flow, enough to be reversible, and they're not dead. And this is what the theory behind recanalization therapies are, okay? So your goal for recanalization is not to save the core that's already dead, it's infarcted tissue. It's to save the surrounding penumbra with some preserved blood flow. So MRIs have become extremely sophisticated over the last 5 years, and we can actually image this concept now and put it on a radiograph. So the top image is what's called a diffusion-weighted image. High signal means it's read as impaired Brownian motion of water molecules. Okay, what happens is if you lose cerebral blood flow, you lose oxygen. If you lose oxygen, the sodium ATPase channel fails, and the normal electrochemical gradient of the membrane fails. Okay, so the cell swells, and that's picked up as high signal on the diffusion-weighted image. The bottom image is what's called a perfusion-weighted image. Okay, and you get a bolus of contrast, and the scan actually measures how long it takes, or the mean transit time for it to reach different areas of the brain. And you can see that compared to the left cortex, or right side of the screen, this area has a large area of penumbra, a large area of reduced blood flow. Your goal for recanalization is to not prevent the top screen to look like the bottom screen. Okay, so you want the area of infarct to stay infarcted, but you don't want the bottom area to become infarcted. So the diagnosis of acute ischemic stroke is still to this day made primarily clinically. Most imaging you obtain in the urgent setting is normal, and you really, really have to understand neurovascular anatomy to know how to do this correctly. And I don't suppose any of you are going to go home and start reading about neurovascular anatomy. And I think the American Heart Association and the NIH recognize this, that not all providers are going to have an understanding of neurovascular anatomy to diagnose acute ischemic stroke. And they came up with this really, really helpful National Institute of Health stroke scale. And this provides a systematic assessment to assess neurologic status without knowing anything about the exam. So you can give a quantitative definition of what their stroke deficit is, and it really, really takes the thinking out of it. Okay, you don't have to know anything about vascular anatomy. You can say this is a measurable neurologic deficit that happened acutely, and therefore it's a stroke until proven otherwise. So this is one of the, this is 4 of the 15 items to assess for speech and dysarthria. So you give the patient the card and you say, can you describe what I'm seeing? And it pretty remarkably brings out someone's aphasia. And the bottom one's assessed for articulation, which can bring out someone's dysarthria. And I didn't really pay much attention to this until we started doing telestroke, and you can really, really see the difference of how it facilitates communication between healthcare providers. So when you're on the phone, you know, I don't have to listen to the ER doctor's like crappy exam. I can just tell him, he can tell me what's the deficit, what are the items you found on the exam, and that way, even when he's transferred, we have an objective assessment to say, did the patient get worse, better, or is he the same? So in regards to the management of acute ischemic stroke, there's 4 things you want to think of. ABCs, emergent neuroimaging, IV thrombolysis, and mechanical thrombectomy. So I'm only going to say one thing about airway. I've noticed, again, from dealing with other ERs, is that there's an impulse to see something on a CT scan and intubate the patient. Okay? You should not intubate patients with strokes for the sake of them having a stroke on a CT scan. If their airway is compromised, that's a different story, but the problem with this is if you look back at all the trials for ischemic stroke and you looked at who got intubated and who didn't, irregardless of stroke size and other comorbid conditions, they invariably did much worse. The benefit of recanalization therapy was lost in patients who got intubated. And part of the reason is because when you induce anesthesia or you do rapid sequence intubation, you transiently but severely drop their mean arterial pressure, and therefore you drop their cerebral perfusion pressure. That transient drop is enough to lower the blood flow in the penumbra and probably infarct that entire territory. So the first imaging modality we're going to use is a plain CT head without contrast. The primary thing you're going to do with this is rule out intracerebral hemorrhage. A very, very intelligent Canadian person came up with these other 2 signs he saw on non-contrast CT. It's blurring of the gray-white cortex, and you can assign a score to this. It's called the Alberta Aspect Score. And basically what happens is that if you narrow the CT window, it really brings out the differentiation between the gray and the white matter. If there's blurring of this gray-white matter, that means it's being filled with something. And in the setting of acute ischemia, it's presumed it's being filled with cytotoxic edema. Additionally, you can see what's called a hyperdense middle cerebral artery, which is just a hyperdense sign seen in even the Sylvian fissures or the suprasellar cistern. So this is something that's changed in the last year and a half, is we frequently obtain CT angiography, and it's to evaluate for what's called the large vessel occlusion. And this is known as the carotid terminus occlusion or a proximal middle cerebral artery occlusion, or an M1 occlusion. So when these guidelines came out, the American Heart Association was extremely unhelpful in determining who needs a CT angiogram in the emergent evaluation of stroke and who doesn't. And in their own guidelines, they wrote, if endovascular therapy is being contemplated, a non-invasive intracranial vascular study is strongly recommended during the initial evaluation of acute stroke, which should not delay IV thrombolysis if indicated. They go on to say that you shouldn't be considering mechanical thrombectomy if the patient's not independent prior to presentation, or if they have an NIH stroke scale that's smaller than 6. So if it's greater than 6, they do recommend it. This creates a lot of problems because there's now no consensus agreement of when to get angiography in the initial management of stroke. And the criticism that came out immediately after this statement was that the NIH greatly underestimates the great degree of deficit, especially if it's a non-dominant posterior circulation problem. It's going to underestimate the degree of deficit. This is an example of that. So at Loyola, we have what's called an opt-out policy for CT angiography. So if there's a suspected stroke in the emergency department or from a telestroke that's brought to our ER, the CTA is automatically ordered, and upon initial assessment, if we feel like it's not necessary, we can cancel the CTA and just do the plain CT without contrast. In the last year, I've never opted out, and this is a reason why. This is a case I had 2 weeks ago. This guy, he presented with acute onset of vertigo, essentially. And on examination, he just had a right homonymous hemianopsia. The plain CT was normal, and he had no other exam findings in central vertigo. So we really thought it was a peripheral vestibulopathy. And then the CTA was already ordered. We didn't opt out. And when we got the CT angiogram, this is his left vertebral artery coursing up to the intracranial portion. And you can see that within the lumen, there's a calcified area, and there's a big old ulcerated plaque right in the left vert. If you follow this up, I didn't add this in the picture, but he also has a proximal posterior cerebral artery occlusion. So now I can tie those things together based on vascular imaging. I can say the guy has vertigo due to posterior circulation disease, and he has a right homonymous hemianopsia from a right posterior cerebral artery occlusion. We treated the guy with thrombolysis, and we got the MRI, and his stroke is much, much smaller than what would be expected for a vascular territory in that occlusion. So I think it's helpful for not only evaluating for large vessel occlusions, but I think it's helpful to know what the vascular anatomy looks like. So the hallmark in the management of acute ischemic stroke is recanalization therapies. You can do this either through IV thrombolysis, which can be used within 4.5 hours of the last known well, or mechanical thrombectomy, which can be used in the last 6 hours of the last known well. So IV-TPA was based on 2 landmark studies. The first one was the NINDS trial in 1995. There were 2 parts. There was a favorable outcome at 90 days compared to placebo. And then the second trial that was done was to extend the window, the ECAS-3 trial. And at 4.5 hours, again, favorable 90-day outcome compared to placebo. There's 2 extremely important points about these studies that I think are worthwhile for you to know. One is that despite there being an increase in intracerebral hemorrhage in the patients that were treated with IV thrombolysis, you're still more likely to be independent in 90 days. Okay, so that's really important. And the second one is there's no mortality benefit to IV-TPA, okay, when measured at 90 days. If you probably looked at these patients in 5 years, I bet more of them are living because you're more likely to be independent, less likely to aspirate, more be able to take care of yourself. But that's never been proven with IV thrombolysis. And there are a lot of contraindications with IV-TPA, and this was a big barrier to treatment in the last 5 to 10 years. When they wrote the exclusion criteria for both the NINDS trial part 1 and 2 and the ECAS trial, some guy just made it up. These were not based on evidence. He just wrote these because he wanted to have the least amount of complications. It was a really controversial therapy at the time. I would say we have violated almost every single one of these, with the exception of these 3. So anyone who has an active intracranial hemorrhage, you're not going to give IV TPA to, no questions about it. And anyone with any kind of coagulopathy, the risks probably outweigh the benefits. For the rest of these, you have to make an evidence-based decision, or not an evidence-based, but a clinical decision, okay? So if the guy has a prior large infarct and is now independent or now doing well, to not treat that guy makes no logical sense, especially if there's no data now that supports that. So those three you should know. If there's an intracerebral hemorrhage or any kind of coagulopathy, he's not going to be a candidate for treatment. But the rest of these are going to be made on a case-by-case decision. So this is the new sexy thing in stroke. It started in 2015, mechanical thrombectomy. So to give you some historical perspective, there were 3 large trials in New England Journal of Medicine in 2013 that were all negative. And everyone thought this was the death of thrombectomy for stroke. They were using the older generation devices. So this is a coil retriever and aspiration device. This is called the Mercy catheter device, and it's a corkscrew-like device. It kind of pokes at the clot and tries to take it out. The second device is the aspiration device, or the pneumocatheter catheter device, and it's more like a vacuum. So there's a guide catheter that goes through the clot, and then it starts sucking back out like a vacuum. The problem with these two devices when they did the trials was the recanalization rates were extremely poor. Some people were getting 50% recanalization, which is not very good. The technology advanced between 2003 and 2015. They have these new stent retrievers, which is you pass the guide wire past the clot, it opens the stent up, and it sucks the whole clot back. And the recanalization rate with these were between 75 and 100%. So they're very good. There's 5 trials that came out after November of 2015 that were all positive for using these stent retrievers. So the AHA updated their guidelines. They recommend only for carotid terminus and proximal MCA occlusion. These are the largest vessels in the brain and therefore the safest to pass the catheters through. But not uncommonly, we'll go after smaller vessels. So distal MCA, proximal ACA, and distal ACA. Some centers, not Loyola, but all the other Chicago area centers will off-label offer thrombectomy from 8 to 12 hours from their last known well time. So back to our case, the patient received IV thrombolysis. She underwent successful M1 mechanical thrombectomy with a solitary stent retriever. This is her CT angiogram pre-treatment. So if you look at the right side of the screen, the left brain, this is the left proximal MCA. Compared to the right, you can see that there's an area of a filling defect consistent with an occlusion. Upon awakening from conscious sedation, she had a completely normal neurologic exam, and she did pretty well after that. So let's do some questions. I think these are somewhat relevant for your boards. A 35-year-old right-handed woman with a history of major depressive disorder presents via EMS after being found down 30 minutes prior. In the emergency department, when asked what's wrong with her, she says motor deficit. On exam, she has left hemiplegia and aphasia. The nurse sees her withdraw her left arm on vein puncture, and her CT and CT angiogram are normal. She has no contraindications to thrombolytic therapy. What is your next best step in management? So you have psychiatry consult, IV thrombolysis, no thrombolysis, admit for stroke mimic, or emergent diagnostic cerebral angiogram. Anyone want to guess? Psych consult. Okay. Can I ask you why you say psych consult? Yes, I agree. But that's the wrong answer. So this is a real case, and this happened not too long ago where we were down in the emergency department, and there are guidelines about treatment for this, and they're evidence-based guidelines. So there's suspicious things here, right? So she's 35. She seemingly clinically has a large stroke. So that's automatically should be a tip-off that you should raise your level of suspicion that something's not right here. You see her withdraw her left arm on vein puncture. So you think of a neurologic deficit as being permanent. So 2 things I'll say about this case. One, you want to categorize it the same way I did before. So this is an acute onset of a neurologic deficit. It's vascular until proven otherwise. Okay, and you treat cases as such. And people used to not be amenable to doing that. And they used to say, well, what if you give this patient IV TPA and she has a large intracerebral hemorrhage? And they looked back at stroke mimics. So giving TPA to a stroke mimic is extremely safe. The complication rate is less than 0.1%. And now we have advanced neuroimaging. We understand that young people have strokes, and young people can have huge strokes. And this was one of them. She had a massive middle cerebral artery infarction. She was in the unit with elevated intracranial pressure for 7 days. So you should treat it as stress. Your clinical judgment is not always perfect. And especially in people with really, really good collateral blood flow, they can have waxing and waning symptoms. So although the neurologic deficit should start acutely, it may wax and wane. So we luckily treated her with IV thrombolysis. I went to sleep that night thinking that I was going to have no problems with this. And then I got called from the ICU 3 hours later that she had an anisocoria. She blew a pupil. I was really surprised. So follow the guidelines. If you're suspecting, if it's acute onset of a neurologic deficit, you should be thinking vascular until proven otherwise. Here's the second case. A 50-year-old right-handed woman with a history of atrial fibrillation presents with right arm weakness and slurred speech that started 30 minutes ago. On her exam, she has a spastic dysarthria and right hemiparesis. Her INR is 2. Her CT head is normal. A CTA shows a filling defect in the left M1 portion. That's a very proximal middle cerebral artery. What is your next best step in management? IV thrombolysis without mechanical thrombectomy. Mechanical thrombectomy without IV thrombolysis. No intervention. Admit to the neurosurgical ICU for Q&R neurochecks, or give her an aspirin or Plavix load, I would say. I already know what the answer is. So I guess we think she's having a stroke. That's pretty reasonable, right? And what contraindication does she have to IV thrombolysis? INR, right? So that's an automatic contraindication to IV thrombolysis. So the question is do you take this patient for mechanical thrombectomy? And in the trials, in the 5 trials that were positive, there were only a very, very small few number of patients that got thrombectomy without IV TPA. And although they had good outcomes, it's 12 patients, we do take these patients for thrombectomy. So the correct answer would be mechanical thrombectomy without IV thrombolysis. Does that make sense? So we're going to switch gears with another case. So this is another real case. It's a 63-year-old right-handed man with a history of atrial fibrillation and COPD who woke with a headache. He said his headache was not intense. He noted that he had difficulty ambulating. He had chest pain and shortness of breath. And he was initially admitted to the medicine service for a COPD exacerbation. And at some point within the first 6 to 12 hours, his headache worsened. So his medications were notable for warfarin. His blood pressure was 160/96. He required repetitive stimulation for arousal. He had a spastic dysarthria and a left hemiparesis. And his INR was 2.2. So again, follow that same logical sequence. So this is an acute onset of a neurologic deficit that localizes to the right subcortical region, right? He has no aphasia, no apraxia. This is vascular until proven otherwise. And I would say, again, it's more likely to be in the anterior circulation and more likely to be in the subcortical middle cerebral artery, the right lateral lenticular striatal vessels. So we're going to talk a little bit about intracerebral hemorrhage. This is this patient's scan. He has a hematoma in the thalamus that extends intraventricularly. And when you talk about intracerebral hemorrhage, it's all about location. Okay, so the first thing is you want to know if it's intraaxial or extraaxial, and within those, what is it? So extraaxial hemorrhages would be like subdurals and epidurals. They're pretty unusual outside of trauma. I know in the bone marrow unit they can have spontaneous subdurals related to thrombocytopenia, but by and large they're related to trauma. And then of the intraaxial hemorrhages, intraparenchymal makes up the large most by far. So over 90% are intraparenchymal hemorrhages as compared to subarachnoid or intraventricular hemorrhages. So that's what we're going to talk about most. There's a lot of different etiologies for why you would have bleeding in the brain. There's all sorts of vascular etiologies. There's certain infections that can predispose to intracerebral hemorrhage, trauma, of course, medications, and then there's certain neoplasms that give you a higher predilection of having or presenting with an intracerebral hemorrhage. The ones I think you should really know and the ones that really come up are hemorrhages related to chronic hypertension, hemorrhages related to amyloid angiopathy, and those that are medication or anticoagulation related. And again, even within patients who have intraaxial hemorrhages, the location is going to tell you a lot of information, okay, because different pathophysiologies have very, very typical locations for hemorrhage. And these 4 on this side are almost always related to hypertension or chronic hypertension. So if you get a scan and you see that the hemorrhage is in the putamen, the pons, the cerebellum, or the thalamus, by probability, it's more likely related to chronic hypertension. And this diagram kind of explains why. So when you have vessels, all these vessels are perpendicular to a large artery, and there's a change in the shear force. Therefore, they're more likely to be damaged by diabetes and hypertension. Okay, lobar, cat's out of the bag. It can be anything. Okay, so it can be hypertension, it can be trauma, it can be medication related. Lobar is non-specific. So the major pathophysiology of ischemic stroke is that it's mechanical disruption caused by the hematoma. And not only is there disruption from the actual blood, but within 5 days you'll have significant amount of edema. And that's both intracellular or cytotoxic edema and extracellular or vasogenic edema. Edema starts on day 0, it'll get worse by day 3, and then it starts to slowly decline. And that's when you see the patient improve. And then the next important thing, and probably the biggest predictor of outcome outside of the actual volume of the hemorrhage, is if the hematoma enlarges. Okay, and this is often due to either continuous bleeding from the initial site or bleeding from adjacent small vessels. So again, neuroimaging has really changed the face of our understanding of this. This is a non-contrast head CT. You can see that there's a large parenchymal hematoma with lateral ventricular extension. The midline seems to be somewhat shifted. If you do a CT angiography on this patient, you can actually see that the contrast extravasates within the hematoma. And that's called a positive spot sign. And what that means is that it's likely the nidus for bleeding. And when you see a positive spot sign, it has almost a 99% sensitivity for predicting rebleeding. The major diagnostic modality here is going to be a non-contrast head CT. And then there's 3 neurology-specific things for management of ICH. So airway breathing, circulation, reversal of anticoagulation, and what to do with the blood pressure. So the reversal of coagulopathy is pretty straightforward, especially with prothrombin complex concentrate. There are different doses. We use different doses at this hospital as part of our rapid reversal protocol. At other hospitals, they always give the maximum dose. So you can give, here, the most commonly used dose will be 25 international units per kg. The maximum dose you can give is 50 international units per kilogram. And because they're on warfarin specifically, you do want to give them vitamin K once and possibly twice. Dabigatran is one of the newer agents. It's a direct thrombin inhibitor. There's now a antibody to this, but it's not at our hospital yet. There's a lot of things have been written in the literature about how you can reverse this. If they ingested within 2 hours, you can give them activated charcoal. Case Western has done dialysis a couple times for these patients. I think it's extremely impractical unless they already have access. But right now, the Neurocritical Care Society recommends they use the maximum dose of 4-factor PCC for all these patients. Same thing with the factor 10A inhibitors. It'll be the maximum dose of PCC until there's another antibody that's readily available. Heparin, this is controversial. Some people just say leave it alone, but if they've given heparin within the last 2 hours, you can give 1 milligram of protamine for every 100 units of heparin. Low molecular weight heparin, same thing. 1 milligrams of protamine for 1 milligram of each enoxaparin dose, and then half a milligram is given within the last 8 to 24 hours. So this is something interesting. This trial just came out in May of 2016. So before there was a lot of controversy of whether you should give platelet transfusions to patients who have ICH and they're on Plavix or aspirin or an NSAID. And this trial uniformly showed it's not nor inferior, it is inferior to standard of care for people who are taking antiplatelet therapy for ICH. Okay, so if you give a platelet transfusion to someone for their aspirin, you are increasing the likelihood they're going to die, and you're increasing the likelihood they're going to live with more morbidity. Okay, and I thought this was really fascinating. This was not the expected result of the trial, and they hypothesized that when you give a platelet transfusion, because it's pro-inflammatory, it actually may occlude collateral perfusion around the hematoma and actually cause an ischemic infarction around the area of hematoma. Additionally, there were at least 3 patients enrolled in the trial that had a prothrombotic disorder in which platelet transfusions are already frowned upon. So the management of blood pressure is also very controversial. The data shows that you should maintain a systolic blood pressure of 140 to 180. It really, really doesn't make sense. The cerebral perfusion pressure is dependent on the mean arterial pressure, and that's primarily closer to your diastolic pressure. So giving someone nicardipine to drop their systolic blood pressure is not going to really change your map all that significantly. Additionally, they didn't get CT angiography on the patients that were treated in these trials. So I just showed you that a spot sign has a 99% sensitivity for hematoma growth, and none of these patients received CT angiogram. But the current guidelines and what the trial suggested was you may have a better outcome if you treat systolic blood pressure 140 to 180. Interestingly, in the patients that were treated under 140 had a worse outcome. They were more likely to develop acute kidney injury in the units. So this is something that I didn't really appreciate until I started neurology. Was hydrocephalus is a real serious thing. Okay, if you occlude your ventricles with blood, you've suddenly lost your brain's primary mechanism to deal with pressure, and that's to drain CSF. And one of the things you have to do if they develop obstructive hydrocephalus without any kind of communication is ask your neurosurgical colleagues to place the external ventricular drain. And this is something you can actually measure on the CT scan to objectify if they develop obstructive hydrocephalus or they should have hydrocephalus related to chronic brain atrophy. So one of the hallmark features in the management of ICH is not doing surgery. Okay, so 2 trials already been done, been known for 10 years that patients who get hematoma evacuation do worse. And this is true for deep hematomas. It's probably true for supratentorial hematomas, but since 90% of our ICHs are infratentorial or deep, it's really important that you know that deep hematomas are not suitable to surgery. Okay, the one exception to this rule is posterior fossa or cerebellar hematomas, and the reason is because the posterior fossa has much less room to swell when there's edema, and if you don't allow for pressure to be released medically, it has to be done surgically. And every cerebellar hematoma should be evaluated for surgery. Seizure prophylaxis is not recommended unless they have a seizure. Don't forget that every single anti-epileptic you give is somewhat depressing to your level of consciousness. So one of the hallmark features of monitoring these patients in a unit is monitoring their mental status and their exam. There's been one study with prophylactic Dilantin. It was associated with worse outcomes, more fever, and specifically worse cognitive outcomes. So they were more likely to be cognitively impaired if you received Dilantin in the unit. It's difficult because even at Loyola, we don't always have continuous EEG monitoring available, and there is a high incidence of non-convulsive seizures. But when they did the risk-benefit analysis, it seems like they still don't benefit from prophylactic antiepileptics. I think this question gets brought up a lot from the surgical services is when is it okay to start venous thromboembolism prophylaxis. So sub-Q heparin is fine within 48 hours of the last head CT. That's based off of retrospective data. And then the other common question we get is when is it safe to resume anticoagulation? So this is where MR imaging is really important. So you will never know if a patient has amyloid angiopathy until you get an MRI. It's impossible. And if you give any kind of blood thinner with someone with amyloid angiopathy, they will unequivocally have a fatal intracerebral hemorrhage. Okay, so I recommend getting an MRI on anyone with intracerebral hemorrhage. It's common, and it happens. Otherwise, in patients with especially deep hematomas that are more likely related to chronic hypertension, as long as they have strict blood pressure control, you can safely restart anticoagulation in 7 to 10 days. And especially in high-risk patients, you want to be aggressive about starting anticoagulation. So if they have a bare metal valve, your threshold to start anticoagulation should be very low if they have a stable CT after 7 days. So back to the second case, the patient was successfully reversed with case centra. Our neurosurgery placed an EVD for hydrocephalus. He had a very prolonged ICU course, and I think after 12 days the EVD was removed. He was doing great in rehab. He had a normal exam, and we were able to resume anticoagulation for atrial fibrillation on day 14. So this is something I want to tell you about. I don't think you even know it exists, but we have a very, very successful simulator here for ischemic strokes and hemorrhagic strokes. The reason is we're trying to develop a system like ACLS where there can be some kind of certificate. We won an award for this at the American Heart Association, so we're really, really trying to make this the standard where people are able to go through the simulator, graduate with their certificate, and say you're capable of dealing with acute stroke just like you are with acute MI or ACLS. So if you're interested in doing this, next year we're enrolling all the medical students. We're getting ER doctors from other sites that we work with who deal with stroke to come and do this. I think it's a really, really fun thing. So if you're interested in doing this, email them or me and we'll get this sorted out. So does anyone have any questions? That was a lot of information. No? All right. Thank you very much.